Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Let's start with two cases. This MRIs at the thigh level from two different patients. So one of the first questions we ask when there is muscle weakness is whether the muscle is abnormal or normal. So clearly both of them show quite abnormal musculature. You can see the fatty infiltration is quite florid both in the anterior and posterior compartments in both cases. The next question usually is whether it is myogenic or neurogenic. So one of the questions is how do we use MRI in dealing with these questions which clinicians go through. So let us look at what are their questions. So when we say about muscle involvement, the abnormality can be at the muscle fiber level, the neuromuscular junction level, the nerve, or the anterior horn cell level. And as we know, the nerve and the neuromuscular junction, the muscle imaging will be usually normal, whereas in the anterior horn cell as well as the primary muscle disorders, the muscle will be abnormal. So that is one of the first things that we look at. Like we saw, the previous one we saw, the two cases could either be anterior horn cell and a myopathy. So where does MRI fit in? Because as we know now, there are more than 1,000 hereditary myopathies. And although there is a distinction between dystrophic myopathies and non-dystrophic myopathies with CK and the way they progress, most often the clinical overlap is quite high as well. And as we know, the genotyping gives us a lot of variance. So muscle MRI definitely plays a role in further narrowing down and sometimes clinching the diagnosis. So the talk today will look at why do we do muscle MRI and when do we image, how do we image, what do we look for, and some cases as well. So as we said, the clinical, the electrophysiological and biochemical, biopsy, genotyping, and the imaging all fit together to confirm the diagnosis. So before confirming the diagnosis, sorry, can't progress. So before confirming the diagnosis, two important things are: one is guiding the genotyping as well as choosing the biopsy site sometimes, as well as once the genotyping is done, is the variant pathogenic or is it significant or is it just a non-significant variant? So those questions can be answered sometimes by the MRI. Once the diagnosis is confirmed, MRI still has a role in assessing the progression as well as assessing the response to treatment. In fact, with the new gene therapies coming, the response to treatment is coming in a big way, and MRI is a non-invasive biomarker in most of these clinical trials. So how to image? What are the standard sequences that we use? The T1 weighted imaging is the first sequence that we look at. It gives a good contrast between the fat, as you can see here, the muscle, the bone, and you can also see the interfacial planes. The next one that we use is the T2 with fat suppression. The T2 with no fat suppression, as you can see between these two images, this is more useful because we are suppressing the fat, and any inflammation or lesional component which has more edema or water content is well seen on this T2 with fat suppression. In some cases, like inflammatory myositis, or when there is a nerve pathology that is suspected, you also do the T1 with fat suppression and gadolinium. Other newer sequences which we have is the ideal T2 sequence, where you get a fat image and a water image. And most of the centers now who can afford the time and the protocol are doing whole body imaging. So whole body pediatric imaging for muscle MRI is very much in the book. Sorry, there's some problem with transition slides. So apart from the standard imaging, which is at the pelvic level, at the thigh level, and at the calf level, you can also do a whole body imaging, which gives you a look at the neck muscles, the skull base muscles, as well as at the upper limb muscles. So what do we look at after obtaining these sequences? One is a fatty change or the infiltration of fat or associated with muscle involvement that is seen as increased T1 signal. And this is a long-term consequence of muscle pathology. The next one that we see is water deposition on T2 weighted images, which is inflammation or edema, that indicates active muscle pathology. This can lead to fibrosis, which is unfortunately reduced in signal on both T1 and T2 images. And as of now, we don't have a method to quantitate the amount of fibrosis. On T1 weighted images, when there is fatty infiltration of the muscle, there is a mercury grading, whereas the first one is less than 10%, 10 to 30, 30 to 60, and more than 60. You don't need to always use this, but this is as a rough guide to how much of the muscle is infiltrated, and also in subsequent MRIs where you can assess progression. So the next thing which we look at is the distribution of muscle involvement, in which you have to look at both the involved muscles as well as the preserved muscles. And why is there a selective involvement? It remained a mystery for a long time, and now we think that it is due to differential lysoform expression during muscle development of the different genes which are involved in these diseases. And again, you have to do a whole body or a standard, and then you look at the pattern of involvement. So we have to, when we said we need to look at the involved and as well as the preserved muscles, we're talking about positive pattern and the negative pattern. In early stages, the involved muscle is a more important one. For example, in this case, you can see that this muscle is involved, whereas the others are literally well preserved. The negative pattern becomes important in the advanced stages of the disease, whereas in this is the same case, that after some time you can see that here the preserved muscles are more evident, and this again helps you in finding the distinct pattern. So here the rectus femoris and the adductor longus both are preserved, whereas here that pattern is not very evident. So in later stages of the disease, the spared muscles are the ones we should concentrate on. So this is going back to the first case. So this case here, you can see there is a difference in the muscle involvement. Here you can see that in the involved muscles, there are a lot of normally preserved muscle islands, and that is a characteristic feature of neurogenic involvement. So here the nerves or the anterior horn cells are the involved areas, whereas this is a primary muscle disorder. So here you can see it is more of a diffuse involvement. Here you can see islands of normal muscle as well as fatty infiltrated muscle. So in some cases, again, are the muscles abnormal? What is the characterization? Can we differentiate myopathic versus neuropathic? What are the other intramuscular patterns? Symmetry? And is there any specific pattern of involvement? So this patient presented with distal weakness and foot drop. And we'll see, we can see that there is mostly the thigh level, there is involvement of the posterior compartment, but the distal involvement is much more common. And here again, you can see the same pattern of involvement of some preservation of the normal muscles. And this is a CMT2 or Dynamin2. So again, it is a neurogenic problem. Another case of proximal muscle weakness. So if you look at how do you make sense of this, so you can look at the diagnostic. There are some diagnostic algorithms. The first question you ask is whether it is, look at the thigh and ask whether it's a posterior or the anterior compartment which is involved. And so in this case, let us look at, sorry, it is not. Okay, so in this case, as we saw, the posterior compartment is not more involved than the anterior compartment. Both are involved. And again, if you look at whether in the calf, which muscle is most involved, you can see that the soleus, the muscle is more involved, and that was a capillinopathy. Another case where you can see that there is again anterior and posterior involvement, and this is a R by R1. But you can see that all these cases are R by R1. So it starts from normal musculature to all different amounts of muscle involvement. So it is quite a heterogeneous pattern, and it is not always that you can make a diagnosis. Another case where you can see the muscles are significantly involved in both the anterior and posterior compartment, but here you can see an intramuscular pattern. If you notice here, there is a centripetal involvement in the rectus femoris. You can see that the center is more involved, and here again you can see a line between the gastrocnemius as well as the soleus. So these two features are very important indicators of collagen 6. Another case with significant involvement of the semitendinosus as well as the tibialis anterior. Although the other muscles are involved, the combination of semitendinosus and tibialis anterior involvement is very characteristic of a tendinopathy. So the specific muscle involvement can sometimes clinch the diagnosis. For example, in a desminopathy, it is a semitendinosus which is involved, whereas in SEPT-M1, you can see that it is the sartorius as well as the semimembranosus that is involved. So we looked at the T1 weighted images. The edema involves on the T2 stir images is suggestive of the disease activity. So this is also important when you suggest the biopsy guidance, which muscle to biopsy. As you can see, these muscles are very fatty infiltrated and they are fat suppressed on these images. So if you take a biopsy from those muscles, the disease activity will be different. And so these muscles which are not fat replaced and maintain the bulk but show edematous changes are the ones that we have to concentrate on for the biopsy. You should also realize that some of these muscles, especially the muscular dystrophies, can have brain changes. So in this muscle MRI, you can see that there is relative preservation of both the semitendinosus as the adductor longus. In fact, they look a little bit hypertrophic. And here again, the anterior and the medial compartments are spared, and there is a relative involvement of the gastrocnemius. The brain imaging of this child shows that there is some disc area along the anterior aspect, and which is more clear on the sagittal sequences where you see polymicrogyria like cortex. And this was the case of DYNE-C1H1 associated spinal muscular dystrophy. So sometimes these extra findings like the non-muscular findings helps clinch the diagnosis. This is a case of right foot drop, and you can see that on the calf level image, you can see there is a significant difference in the muscle mass between the two sides, and on the right side you can see that the anterior and the lateral compartments are really small compared to the contralateral side. So is this a muscle pathology or a nerve pathology? Being very unilateral, it is likely that it is a nerve pathology, and we can in fact see at the pelvic level that this is a sciatic nerve here which shows significant thickening as well as enhancement. And this was a right sciatic perineurioma, as you can see on these images as well. The entire sciatic nerve on the right side is quite thickened. So one more thing is we usually image at the common peroneal level near the head of the fibula, but the common peroneal component of the sciatic nerve can be involved, and it is very important that you image right from the pelvis to the common peroneal nerve. So what's trending in the muscle MRI is, as we saw, the whole body MRI can be done. Many fast sequences are coming, and the pattern recognition that we try to look at can be done by AI. And as we said, MRI is coming up in a big way as a biomarker. And there is the Sniya MRI initiative where they look at the AI in pattern recognition. There's also a platform to share confirmed genetic cases so that everyone gets to see the patterns. So to sum up, what we look at in the muscle MRI is the muscle is abnormal or normal, because you can say that it is either at the muscle level or the anterior horn cell level if the muscle is abnormal. Then look at the distribution and intramuscular patterns. Don't forget the nerve or the brain abnormalities, and always remember that it is a combination of things, the clinical, the biopsy, and the genotype correlation coming to clinch the final diagnosis. Some useful resources. This is a very good site, the Washington University site, where you get where they give all the cartoons as well as the MRI images of different diseases, and this book as well. Thank you.